Okay, so the European Society and the American College of Cardiology guidelines for coronary artery revascularization advocate radial first strategy as the default approach for PCI regardless of clinical presentation. We all know that the commonest complication of transradial access is radial artery occlusion, and distal radial artery access was expected to have lower radial artery occlusion. The aim of this study was to assess superiority of distal radial access over transradial access for forearm radial artery occlusion. This was an international multi-center randomized controlled trial which excluded patients if there was non-compliance with the study protocol, patients on long-term hemodialysis, patients of STEMI, patients of CTO requiring PCI, and all other patients suitable for both distal and transradial access with the 6F glide sheet slender were included. The operators were all well experienced, regularly performing transradial access PCI, including in acute coronary syndrome, and had independently performed a minimum of 100 procedures by distal radial access. Randomization was done online using a computer algorithm. The primary endpoint was radial artery occlusion by vascular ultrasound at discharge, which was usually 2 days. The secondary endpoints included access site crossover, hemostasis time, and access site complications. The important point in the methods is that best practices to reduce radial artery occlusion were implemented, and patent hemostasis with air-filled compression device was used for transradial access, and that included ulnar compression as part of the PROFET protocol. For distal radial access, patent hemostasis was not done, and it was done per hospital practice. As can be seen, 12% of the patients actually had bandage used for distal radial access. The power calculation for sample size came up with 1,300 patients, which were roughly equally divided between the two groups, distal and standard transradial access. In the results, there was no significant difference in forearm radial artery occlusion, overall bleeding events, vascular complications, access site bleeding events, access-related pain assessment. What was different, however, was that hemostasis time was shorter, radial artery spasm occurred more with distal radial access site crossover rates were higher, and the distal radial artery access time was also higher. It's pertinent to bring into discussion the data STAR study, which was our study done retrospectively comparing distal versus transradial access in small radials, which was presented at the TCT in 2018 by me and published in Indian Heart in 21. The important point is we used bandage in this study for hemostasis, which was removed after 12 hours, and patent hemostasis was not done. This was done for logistical reasons. And we found, like in discoradial, that distal radial artery access takes longer because of access delays. It fails more often because of access failures, and there's no difference in vascular complications as in the discoradial. We found forearm hematomas occurred only with transradial access, and there was no significant forearm hematomas in the distal radial group. But the important point is, though there was no significant difference in radial artery occlusion for transradial or distal radial access, the important point here is if you look at data STAR, the radial artery occlusion was under 3%. As you see, transradial access was 2.1 and distal radial was 2.4 at day 1. But in discoradial, these are significantly lower. As you see here, it's almost 0.3 and 0.91%. Now that was because of the best practices for preventing radial artery occlusion. Then we looked at prima facie TRI, which was a study we did in 2013. And you see the transradial access, the radial artery occlusion rate was only 0.46%. And compared to our radial artery occlusion at 30 days in data STAR, that's significantly lower, and that's again because of best practices for reduction of radial artery occlusion, which we had actually used in the prima facie TRI, which included pre-procedure ultrasound measurement of radial artery size to minimize sheath size radial artery mismatch. We used adequate anticoagulation, minimized compression and pressure and compression time. Ulnar compression was used wherever we found the radial artery was getting occluded in the follow-up period, and avoidance of bat and cat. It's important because patent hemostasis requires strict vigil for early detection or development of forearm hematomas. Otherwise, these can go into a compartment syndrome. And if that cannot be done for logistical reasons, as happened in the data star with our study, then the trade-off is increased radial artery occlusion, as was noted in the data star, though it was still under 3%, which is same as Prophet 1. And the best practices used in the discoradial were adequate anticoagulation, effective spasmolytic treatment, slender 6F sheath, patent hemostasis, and extensive transradial expertise. The conclusion from discoradial is that this study sets a new benchmark for equally low radial artery occlusion rates for radial and transradial access and distal radial access. Although distal radial fails more often because of access site crossover rates and access failure, the hemostasis time was shorter. And the perspective based on current evidence from several randomized and non-randomized studies and meta-analysis is that at the expense of more access failure, more access time, distal radial artery access takes less time to hemostasis and there is less forearm hematoma. And the jury is still out on radial artery occlusion. The meticulous application of radial artery occlusion prevention practices is the key to achieving low radial artery occlusion. This and a lot of other aspects of transradial interventions are included in this comprehensive book, which is due for release, the Handbook of Transradial Interventions, which will be out soon. Thank you for your attention.